Moyen, Mesdames et Messieurs, good afternoon, ladies and gentlemen. First of all, I would like to thank the organizers for the possibility to talk to you about end-of-life care for people with dementia. This is an umbrella title for my more specific task of introducing you to the so-called care oasis as a new kind of setting in dementia care. More specifically, I will talk about the implementation of this setting into nursing homes in Luxembourg and the evaluation of this process. The care oasis was invented and for the first time implemented in the Swiss nursing home Haus Sonnweit in 1998. In Germany, its introduction through the literature initiated a highly controversial debate. 2006, the Seniorenzentrum Holle, a privately run nursing home for people with dementia, decided to implement its own care oasis. DementSupport did the scientific evaluation of this implementation process. Against the background of this evaluation experience, the Luxembourg Ministry of Family and Integration commissioned DementSupport with the elevation of the two oases in Luxembourg. When speaking of end-of-life care, let me stress that the term does not refer to a temporarily limited lifespan. Rather, it refers to the care of people with dementia in highly advanced stages. Following up on our original evaluation in the Seniorenzentrum in Holle, we are now doing a long-term study there. In this context, we still accompany 3 residents and their families who were among the group of 6 persons originally moving into the Holle Care Oasis in 2006. Oh. Okay. Who is cared for in a care oasis? As already indicated, a care oasis is designed for persons with dementia in far advanced stages. In this particular group, people tend to be in need of severe physical care. Also, they often will show strong impairments in their verbal communication skills and in their mobility. We are talking about persons who completely depend on others for the satisfaction of their social, psychological and spiritual needs. However, with the growing number of care oases being implemented, these criteria are being expanded and changed. What is a care oasis? Generally speaking, I would define a care oasis as an answer to a problem in dementia care practice, invented by care practitioners. In a first approach, it can be defined as a room in which 5 to 8 or 9 persons can live together as a community. A second criterion is that there is a constant presence of a professional care person in this room during the day. One of the 2 care oases in Luxembourg even secures the presence of a professional carer at night. A care oasis is about need-oriented services and interactions, about ameliorating suffering, about pain management and reducing states of fear and anxiety. It is designed for a type of resident who, because of his or her severe reliance on care, will tend to predominantly stay in his or her own bedroom in a given conventional setting. Staying on your own for most of the time in this particular condition increases the danger of social isolation. This is why I said that a care oasis is first of all a solution to a problem in dementia care practice. The differing examples of implementation as well as the mistakes made in the implementation process help to narrow down the features of an ideal realization with regard to construction and design. In short, the following are central aspects of a care oasis as a physical setting specifically designed for people in far advanced stages. Meals are taken together, which requires space for a table and chairs. The single residence individual space is equipped with a nursing bed and furniture. Protection of privacy is secured by blinders or paravents or curtains. There is a bathroom for taking a relaxing bath and a therapeutic space, which, for example, is equipped with a waterbed. Such a bed can help residents to find some relaxation. In order to have some flexibility with regard to the necessity to assist residents in taking their meals, it is helpful to have a kitchen with facility for keeping food warm. Access to an outdoor area facilitates stimulation via fresh air, light and sounds. A room to retreat to in critical life situation, which can also be used by relatives. What is important is sufficient floor space. In 2007-2008, the setting of the care oasis was implemented in 2 care institutions in Luxembourg. Both facilities had planned a new building to include a care oasis. One of the 2 operators, the Association Luxembourg Alzheimer, was a newcomer in the area of running a long-term facility. ALA built and started to operate the residential care home beim Goldknapp, which is home designed for people with dementia exclusively. Here, dementia care is based on the implementation of the so-called Hausgemeinschaftskonzept, the concept of living in small groups. I think you know them from Anton Pikoff-Kon 2 and Group Bünde. In small groups as normally as possible in-house community. It focuses on the creation of an atmosphere of ordinary daily life, for example, by having the meals prepared and eaten in the kitchen of the living unit. The other care institution, the Centre Hospitalier Neuropsychiatrique, has a 150-year-old history in caring for people with psychiatric disease. Which the Centre Pontalis expanded to care for elderly people in cooperation with the community of Edelbruck. While both facilities planned their OAs with an eye on how Sonnenweit, they clearly differ from the Swiss model in terms of group size and target group. Planning a care setting without any experiential background requires changes to be made when planning errors become evident in everyday practice. Accordingly, both homes reduced the group size in their care oasis and also modified their conceptual emphasis. This is a floor plan of the care oasis beim Goldknapp. It consists in a large room, 183 square meters, confined by 2 offices and a large terrace, which has a barrier-free access. The bathroom is situated outside of the oasis, just opposite the entrance. In the course of the evaluation process, it became evident that an occupancy of 12 persons was infeasible on this floor space. Thus, in actual practice, no more than 9 persons have ever lived and been cared for this oasis during the time of the evaluation. This is a floor plan of the care oasis at Centre Pontalis, run by CANP. The floor space of 85 square meters for 5 persons, a single room including a wet cell, a bathroom and an additional wet cell was laid out for 6 persons. During the evaluation process, 1 bed was taken out and a water bed installed instead, which is used for therapeutic purposes. The physical environment, there you have some topics. One of the topics is privacy. And privacy you can secure by closets and screens, how ALA did, and the CANP by curtains. There are also room for for retreat if it's provided. Both care oases have established a community center for having meals together. The quality of the indoor environment is secured by an air-conditioned system. In both oases, a light concept has been implemented. In the Ala home, the oasis is illuminated by a starry sky. At CANP, the lighting concept includes changes in the color range during the day. The evaluation was carried out between April 2008 and March 2010. The decision was for a longitudinal comparative study with control group. One of the explicit objectives was to work towards assessing residents' quality of life in the oasis. Since it is not feasible to directly inquire these residents, what can be done is assessing their quality of life by judgments made by third parties or by observations. In order to evaluate the results of such assessments, they must be compared with persons living in other care settings. The study design also implied an evaluation of the oasis from the point of view of care staff and family members. Last but not least, the evaluation also evaluated the strain experienced by staff in the oasis. For the remaining part of my presentation, I would like to focus on the residents and their situation. The database. Based on the study's objectives, we used a mix of quantitative and qualitative methods. All in all, we did 71 partly structured interviews with relative care staff and management. A time recording device normally used in trade allowed to measure contact time and contact frequency between care staff and residents. All in all, we evaluated about 3,500 hours. In order to assess the resident situation, a whole set of differing instruments was used at 6 different measuring times. Observation made by relative and staff members, together with our own observations, allowed us to at least approximate an assessment of residents' quality of life. The sample. A control group was established in both homes. The ALA sample includes 6 oasis residents and 6 members of the control group. All members of the sample suffered from multimorbidity, but most of them had Alzheimer's disease. The mean age was somewhat higher in the control group. Moreover, the control group's cognitive performance was somewhat better than found in the oasis residents selected for the sample. You see in the fast, moderate to severe cognitive impairments in the control group against quite similar, a little bit better. The CANP sample includes 5 oasis residents and 6 residents of the control group. All members of this sample also suffered from multimorbidity. And you see here the difference in the diagnosis of the dementia. The mean age was almost comparable. In both groups, most of the residents showed severe cognitive impairments, even though the sample also included 1 or 2 residents with somewhat better cognitive competences. What makes this case somewhat special is the heterogeneity of the target groups. This is to say that the control group also had some most apoplexy patients who showed severe impairments in the beginning of the study while regaining competences after several months. The Bartle Index assesses residents' independence. 100 points attest unrestrained conduct of life. In both oases, the resident groups clearly differ in their initial score. At ALA, the scores are relatively stable around 20, and at CANP, the level they level off around 5 points. The score of 5 means, for example, that such a person is in need of assistance in terms of food intake. While the ALA control group shows a clear decline in the scores, the CANP control group shows little improvement over time. This finding must be interpreted in the context of the specifics of the target group. The assessment of challenging behaviors measured with the Cohen-Mansfield agitation inventory supports a reduction of these behaviors for both groups in the OASIS residence, even so the initial values clearly differ in both groups. Both control groups show an increase of such behaviors. In this context, it must be mentioned that in both OASIS, staffing is better than in the other unit, where the control groups live and are cared for. In ALA, care in the control group focused on offers made in the group. However, within progressing dementia, individual offers and services seem to take on greater significance. In such a situation, participation in a group activity may even lead to overstimulation. In the case of CANP, the increase of challenging behavior in the control group can be interpreted in the context of the ethiopathology of apoplectic stroke. While in the beginning of the study, some residents were severely impaired in their everyday competences, so that verbal utterances were not possible, the course of disease showed a positive built-up competence. However, this also implied the possibility to express resentment with regard to one's situation and to react to the environment by expressing reluctance and rejection. An assessment carried out with the quality of life in late-stage dementia instrument demonstrates similar scores in both OASIS. While the best and maximum score reached was 11 points, the score of 20 to 25 points suggests a good quality of life found in both OASIS. The quality of life in the control group is evaluated quite similarly and shows a deviance of just about 5 points. When evaluating the statements made by relatives and staff members with regard to well-being and behavior-related competences, the following description of OASIS resident emerges. The gain in weight found for many OASIS residents is to be interpreted in the context of meal situation, which is carefully arranged on a small group and adjusted environment. Residents' improved physical situation can also serve as a basis for a number of further aspects. For example, in the course of the study, relatives and staff observed a heightened alertness on the side of residents. Now, what can such an improvement of the level of alertness mean? In the former care situation, when staying in a single bedroom, for example, some person with dementia had frequently not even opened her or his eyes any longer. In the care OASIS, this is often observed as a first behavioral change. Staff members describe that residents follow them with their eyes and that they keep eye contact. Staff members and relatives report on reactions to the environment when, for example, residents respond to light stimulation. Changes are explicit in cases where, for example, a resident adequately answers a question or responds to a staff member by a smile. This is a quote. Now, she looks at me much more frequently. Before there was always the empty gaze or this kind of looking right through me. Meanwhile, she blinks and looks you in the eyes. Also, it was possible to observe contacts and interactions between residents and staff members, but also in between the group of residents. It was also observed that some residents are now able to relax, which is also related to a reduction on their anxiety states. Residents are able to calm down and they can sleep better. There has been a reduction of challenging behaviors. Another noteworthy aspect is the fact that one resident in the Ala Oasis actively chose the oasis as her place to live. The home allows a lot of space for walking around and going here and there. This resident, who walked through the home a lot, always returned to the oasis in order to stay and take a rest there. Since this resident then ended up to predominantly stay in the oasis, this was interpreted as a sign that she likes to stay in this place. In agreement with her relatives, this led to the discussion of a relocation followed by her actual moving in. All of these observations lead to the question, are all of these changes caused by the setting of the oasis? In trying to provide an answer, I would like to focus on two aspects. The core quality of the care oasis is the presence of care staff. This secures the possibility of an immediate reaction to residents and allows for care processes to be oriented at resident needs. The chart shows the frequency of contact in the two care oases. On the average, we find about 24 contacts per day between staff and residents in the oasis. In this respect, the two oases are quite similar in their contact density. By comparison, there clearly is reduced contact in a traditional residential setting. Even so, the residents in the control group receive a similar amount of time dedicated to them. Time is distributed between fewer intervals. This has a relation to the normal organization of care in the home, which is a workflow oriented towards securing personal hygiene, bedding intervals, and the providing meals. In the context of the ALA setting based on the house community, we found 70 contacts during the day. This greater frequency of contact emerges can be ascribed to the emphasis the settings care concept plays on group activities. However, with the processing condition, such group activities can lead to overstrain and provoke challenging behavior. In the oasis, the quality lies in the single interventions and the presence of care staff. A comparability of results between two care institutions is difficult because of existing differences with regard to target groups and the respective staff concept with its related staffing. A further difficulty lies in the evaluation of residents' situation in comparison to the control group. This is also something where framing conditions come into play. In the oasis evaluated by our study, staffing is better than in the control group. Moreover, the changes relate to the cause of a given condition and to the cause of the disease. Therefore, it is possible to observe processes of dementia-related degradation and to also describe effects of improvement months after the occurrence of an apoplectic stroke. Yet it is also possible to observe positive changes in the care oasis during the evaluation period. One such change regards to the heightened level of alertness, which I have already mentioned. Another change is the positive development in terms of body weight, which suggests an improvement of residents' general condition. Another piece of evidence of well-being is the reduction of anxiety. The fact that there is more contact between staff members and residents is certainly a reason for these changes to come about. In any event, it can be stated that so far the study of care oasis has not delivered evidence that this setting implies any disadvantages for residents. Thank you for your attention.